So welcome to the class. So today we will discuss about fetal monitoring in labor, NICE guideline, which is published in 2022. Okay. So what does this guideline tells about the assessment during the labor and methods for fetal monitoring? The general principles of the monitoring are perform and document systemic assessment of the condition of the woman and unborn baby every hour or more frequently if there are concerns. So how frequently we are supposed to do? Every hourly we are supposed to monitor the mother as well as fetus, and more frequently if there are some concerns. Okay, so frequency 1 hourly. Okay, now what does the guideline say further? It says that these hourly monitoring assessment needs to be discussed with the woman, and then we have to base our recommendation about the care in the labor on her preferences. That is a shared decision making. Okay, so this is one of the important feature, that it is a shared decision making. You have to take into the views of the woman. So we will discuss the findings, but we will respect the wishes of the woman. So what we are going to see: one, the frequency, length and strength of the contractions, then any antenatal or intrapartum risk factors which can cause fetal compromise, the current well-being of the woman and unborn baby, and how the labor is progressing. That is the overall progress of the labor you have to take into account, and then draw some conclusions or make some decisions and discuss with the woman regarding the further plan, and along with the birth companion if she feels it is appropriate. Okay, so this is what the guideline says. So it is a shared decision making that is going to be very, very important. Next, FHR monitoring is a tool to provide guidance on the fetal condition and not a standalone diagnostic tool. So you cannot say that this FHR monitoring is a alone diagnostic tool. You have to take into account the maternal factors, the status of the baby, the labor progress. All these factors are to be taken into account. So not only the FHR monitoring, but the rest of the parameters are also important. The findings from the monitoring need to be looked at together with developing clinical picture for both woman and a baby. Ensure one-to-one support care is maintained by a midwife, and she should be with the woman throughout the labor. If the midwife needs to leave the room or there needs to be change in the staff, the woman should be aware of this particular thing. So these are very minor things, but they are mentioned in the guideline. Now, what is the initial assessment? So when you see the patient in the labor for the first time, what do you have to do? You have to do an initial assessment of the antenatal risk factors for the fetal compromise at the onset of the labor. Okay, so whether this woman has got any antenatal high risk factor which can cause a fetal compromise, that you need to take into account. And then accordingly we will decide whether she requires an intermittent auscultation or she requires a CTG monitoring, that is the electronic fetal heart rate monitoring. So intermittent auscultation is one method and other is a CTG. So which monitoring is to be offered to her, that we are going to do in decide in the initial assessment. Take into account the recommendations for fetal monitoring for women who are considered to be at higher risk of complications during labor because of existing medical conditions or obstetrical complications. Okay, or for women with multiple pregnancies. So there are specific recommendations given by the NICE guideline. Now explain to the woman, this is a very important slide, explain to the woman that if there are no identifiable risk factors for fetal compromise, suppose that particular patient is an absolutely low risk patient, there are no identifiable risk factors for fetal compromise, you have to explain to the woman that there is a risk of increased interventions with continuous CTG monitoring compared to the intermittent auscultation, which may outweigh the benefits. So have you understood this particular? So if the patient is a low risk, there are no identifiable risk factors which can cause fetal compromise, then you need to discuss that if you go for continuous CTG monitoring, it may lead to increased risk of intervention than the intermittent auscultation, and that the risk will outweigh the benefits. Okay, risk in the sense the risk of intervention, I mean to say. Okay, then advice she is given by her midwife or obstetrician on the method of fetal heart rate monitoring will take into account the whole clinical picture. So whatever we are going to suggest, that will be decided on the whole of the clinical picture. Okay, But if it is a low risk patient, the intermittent monitoring is recommended. Is that clear? Okay, so now let us go to the intermittent auscultation. Now, offer women with a low risk of complications fetal heart rate monitoring with intermittent auscultation when an established first stage of labor. So once the patient goes in established first stage of labor and the patient is absolutely low risk, what we are going to offer her? Intermittent auscultation. Okay, because we know that for low risk patient there is an increased risk of intervention if the continuous ETG monitoring is done. Okay, so intermittent auscultation is a method of choice for patients with low risk of complications. Use either a Pinard fetoscope or Doppler ultrasound. Okay, carry out intermittent auscultation immediately after a palpated contraction for at least 1 minute, repeated at least every 15 minutes, and record it as a single rate on a partogram or in the woman's note. Now, this particular sentence is very important. How do you record? Okay, when you will start recording, when you will start this auscultation? After the palpable contraction. Once the contraction is over, then you will start this auscultation, and you have to auscultate for 1 minute, and you will repeat every 15 minutes, and you will record it as a single rate. Say for example 125 or 120. You can't say 120 to 130. Okay, so it has to be a single number. Okay, so intermittent auscultation is to be done immediately after the contraction, and it is to be done at least for 1 minute, and you have to repeat every 15 minutes and record it as a single rate on a partogram in the woman's notes. Sometimes they give you confusing options in which they will mention that it is to be done for 30 seconds, for 15 seconds, and then multiplied by 4, 30 seconds and multiplied by 2, repeated by every 20 minutes, every 10 minutes, every 30 minutes. These are multiple options which are given. So if you know the guideline properly, what does the guideline say? To be started after the contraction is over, then at least 1 minute you have to auscultate, and every 15 minutes you will go on auscultating and record it as a single rate on a partogram. This one sentence you remember completely. Then record accelerations and decelerations along with this particular heart rate if you can hear. So these accelerations and decelerations are on auscultation. Did you get it? Okay, so on intermittent auscultation, then palpate and record on the partogram the maternal pulse hourly or more often if there are concerns to ensure differentiation from between the maternal and fetal heartbeat. So when you listen or auscultate at the same time, you need to auscultate the feel for the maternal pulse also and differentiate maternal pulse and the fetal heartbeat. Okay, so if no heartbeat, fetal heartbeat is detected, offer urgent real ultrasound assessment to check the fetal viability. This is also one of the questions that you have taken the patient for intermittent auscultation, or the midwife is not able to hear the fetal heart. What will be the next step? You will offer the real-time ultrasound for fetal viability. So this is also one of the question. Okay, so this slide which we discussed has got 1 or 2 SDAs. Then once the woman has signs or is in a confirmed second stage of labor. Now what we have seen is in the first stage of labor in the last slide. Now the woman is in the second stage of labor. Then what should be the frequency of the monitoring? Perform intermittent auscultation immediately after a palpated contraction for at least 1 minute. Again, after the contraction, you will do it for 1 complete minute, but repeat at least every 5 minutes. Okay, so first stage it was for 15 minutes, second stage every 5 minutes you will auscultate for 1 minute and record it as a single rate on a partogram or in the woman's notes. Palpate the woman's pulse simultaneously and differentiate between the maternal and fetal heart rates, and if there are concerns about differentiating between the two heart rates, seek the help and consider changing the method of fetal heart rate monitoring. Okay, so this is what is the first stage of monitoring and the second stage of monitoring frequency. Okay, is it clear up to this much?
Yes, sir.
Okay, now we go ahead with the intermittent auscultation. If on intermittent auscultation there is an increase in the fetal heart rate by 20 beats per minute or more from the start of the labor, or if you hear the deceleration, what do you have to do? Now you are doing an intermittent auscultation, but you have find that there is a shift of the baseline above the previous finding by 20 beats per minute. Okay, or there are deceleration. If you, then you will carry out intermittent auscultation more frequently. Say for example, after 3 consecutive contraction, initially we were on every 15 minutes we were doing. Okay, now after every 3 contractions you will do. So what happens, they will ask you the next step. They may give you that the initial finding was this baseline fetal heart rate, and now it is increased to 150. So initially it was say 125, and now it has become 150. 150 is also normal, 125 is also normal, but it is increased by 20 beats per minute than the previous. In that particular case, what will be the next step? You have to increase the frequency of intermittent auscultation. Okay, so that is going to be the next step, and carry out the full review. So you will carry out the full review, taking into account the whole clinical picture, including the antenatal factor or any new intrapartum risk factors, maternal observation. So overall, what you are going to do, the complete full review you are going to do, and you will also note the uterine contraction frequency, etc., etc. If the fetal heart rate concerns are confirmed, now you confirm that there are fetal heart rate concerns, then you will summon the help, advise continuous CTG monitoring. So on intermittent auscultation, first thing you notice that there was a difference in the 20 beats per minute, or there were deceleration, then you started increase the frequency first. Okay, and in that also you find that yes, there are concerns, then you summon the help and go for continuous CTG monitoring, and explain to the woman that and her birth companion why it is recommended, this CTG monitoring is recommended. Okay, and the implications of her choices of type and place of care. Okay, transfer the woman from midwifery led care and obstetric led care, providing that it is safe and appropriate to do so. Okay, suppose if the patient is in the midwife led unit. Okay, so the midwife led unit does not have operative care. Now these patients will require operative care. Okay, so there is a midwife led practice in the United Kingdom. Now these patients will require shifting depending upon these parameters. Okay, whatever will be the findings of the CTG, she will require a transfer. That needs to be taken into account. So what you have understood here, if you hear the deceleration, and if you there is a shift of baseline above the previous finding by 20 bits, in that particular case we do not directly go to CTG monitoring. What we do, we increase the frequency of monitoring to every 3 beats per minute. Then you monitor the patient, you do the complete review, and if you confirm yes there are decelerations, then you summon the help, and then you put the patient on the monitoring. So even the options will be given, you see what exactly the options are and what is the most suitable option. Directly don't go for the continuous CTG monitoring. Okay, so these other things are also important. Now return to intermittent auscultation. If continuous CTG monitoring has been started because of the concern arising from the intermittent auscultation, but the CTG stress is normal after 20 minutes. Okay, unless the woman decides to remain on a continuous CTG monitoring. Now what was there? The patient was on intermittent auscultation. In that particular case, there were some concerns. So we increased the frequency. We found that there were concerns. So we put the patient on CTG. Now on CTG, it reflects that the CTG is normal. In that particular case, then for 20 minutes, okay, you have to see for 20 minutes. And if it is normal, then you have to shift back to the intermittent auscultation, provided there are no other associated factors, intrapartum risk factors which are developing, and the woman also wishes that we should go back to the intermittent monitoring. Okay, now advise continuous CTG monitoring if the fetal heart rate concerns arise with intermittent auscultation and are ongoing. So that means there on intermittent auscultation there were concerns and they are still there even on CTG monitoring, then she will be on continuous CTG monitoring. Or there are intrapartum maternal or fetal risk factors which are developing. In that particular case, CTG we will advise continuous monitoring. Okay, now which patients require a continuous cardiotocography? Up till now what we have seen is about the low risk patient, intermittent monitoring, because the risk of intervention is high. Now intermittent monitoring in the first stage we have seen, intermittent monitoring in the second stage, the frequency we have seen. Now if we get some concern in the intermittent auscultation, we are going to increase the frequency to every 3 contractions, monitoring every 3 contractions. If there are concerns, then we will put on CTG monitoring. If the CTG is normal for 20 minutes, then we will go back to intermittent auscultation. If they are persistent, then we will monitor the on continuous. Is it clear up till now? Is it
Yes,
clear?
sir. Yes,
Yeah.
sir.
Now the next is a continuous cardiotocography. Okay. Now offer continuous CTG monitoring as a part of fetal assessment if there are antenatal or intrapartum risk factors for fetal compromise. Okay. Now if there are antepartum factors or antenatal factors or intrapartum factors. Now what are these factors? Okay. Discuss with woman and her birth companions the reasons for offering continuous CTG monitoring and explain. So we have to explain that we are going to this continuous CTG monitoring is being offered to this particular woman, and a combination of antenatal risk factors, intrapartum risk factors, and continuous CTG monitoring are used to evaluate the baby's condition in labor. Continuous CTG monitoring is used to monitor the baby's heart and the labor contractions. It may restrict her mobility and the option to labor in water. So once you put these patients on continuous monitoring, the mobility gets affected. Not only that, she cannot go for water birth. Okay. So these particular points are very important. Okay. You have to explain that. Then a normal CTG trace indicates that the baby is coping well with the labor. Changes to the baby's heart rate pattern during the labor are common and do not necessarily cause concern. However, they may represent developing fetal compromise. So maintaining continuous CTG monitoring is advised. So it is not a short-term review of that particular CTG. It is overall picture which is to be taken into account. If the CTG trace changes or is not normal, there will be less certainty about the condition of the baby, and so maintaining continuous CTG monitoring is advised in conjunction with the full assessment, including checks for developing intrapartum risk factors such as presence of meconium, sepsis, slow progress of labor. So all these factors are to be taken into account. Advice about her care during the labor and birth will be based on assessment of several factors, including her preference, her condition, and the condition of the baby. Okay. Now, what are the indications for continuous CTG monitoring in labor? Okay, there are specific indications for continuous CTG monitoring. Now, these indications will depend upon antenatal risk factors, then intrapartum risk factors, or if new factors develop during the process of labor. All these factors will make us to go for continuous CTG monitoring. Now, antenatal risk factors offer continuous CTG monitoring to women if it is in their personalized care plan. If she has antenatal, it is discussed, various options are discussed, and it is accepted by the woman that she wants to go ahead with continuous CTG monitoring, then it will be continuous CTG monitoring. Second, offer continuous CTG monitoring for women in labor who have any of the following antenatal maternal risk factors. So the risk factors may be maternal or it may be fetal also. One, it can be previous cesarean birth or other full thickness uterine scar, any hypertensive disorder needing medication, prolonged rupture of membrane, where but if the woman is already in established labor at 24 hours after the rupture of membrane, she does not require CTG unless there are other concerns. Okay. So PROM we are going to include, but if the patient goes in spontaneous labor within 24 hours and there are no concerns, she does not require CTG monitoring. Any vaginal blood loss other than show is an indication for CTG monitoring. Then suspected chorioamnionitis, maternal sepsis, pre-existing diabetes type 1 or type 2, and gestational diabetes mellitus requiring the medications. Now, if there are any antenatal fetal risk factors, what we have seen up till now were the antenatal maternal risk factors. Now if she has got any antenatal fetal risk factors such as non-cephalic presentation, breech, transverse, oblique, or cord presentation, including while a decision is made about the mode of the birth. Okay. Fetal growth restrictions, estimated fetal weight below third centile, Small for gestational age, estimated fetal weight below 10th centile. So there is a difference between the fetal growth restriction, where the EFW, expected fetal weight, is below 3rd centile. SGA is weight below 10th centile, with other high risk factors such as abnormal Doppler scan results, reduced Leica volume, or reduced growth velocity, etc. Then advanced gestational age, more than 42 weeks at the onset of established labor, is an indication for continuous CTG monitoring. Anhydramnios or polyhydramnios, reduced fetal movements in the last 24 hours before the onset of the regular contractions, is an indication for CTG monitoring. So what we have seen is antenatal risk factors, which may be maternal or which may be fetal. So any malpresentation, then SGA, FGR, or postpartum babies, oligohydramnios, polyhydramnios will require CTG monitoring. Now, continuous CTG monitoring is to be considered if, based on clinical assessment and multidisciplinary review, there are concerns about other antenatal factors not listed above that may lead to fetal compromise. So if it is a multidisciplinary decision which is taken considering the overall picture in that particular case, even if it is not listed in this factor, she will require a continuous CTG monitoring. Now coming to the ongoing risk assessment, carry out a full assessment of the woman and her baby every hour. At each assessment, what we are going to see, maternal antenatal risk factors we will take into account, fetal antenatal risk factors, any new or developing intrapartum risk factor, or progress in labor, including characteristics of contraction, frequency of contraction, strength and duration of contractions, fetal heart rate monitoring, including changes to the fetal heart rate. So that is what we have to check periodically. Discuss with the woman and any changes identified. Okay. Obtain an in-person review of every hourly assessment by another clinician, that is a fresh eyes for women on CTG, to be completed before the next assessment takes place. Okay, so you always take the someone else's, that is senior clinician's opinion also. Now intrapartum risk factors. Up till now we have seen antenatal risk factors. Now intrapartum risk factors. Be aware that the intrapartum risk factors may increase the risk of fetal compromise, and that intrapartum risk factors that develop as the labor progresses are particularly concerning. Now, offer continuous CTG monitoring for women who have or develop any of the following intrapartum risk factors. Now, these here also there are 1 or 2 SBAs, so please concentrate carefully. Contractions that last longer than 2 minutes, or 5 or more contractions in 10 minutes. So if there is a hypertonus, that is contraction more than 2 minutes, or if there are contractions more than 5 in 10 minutes, you will go ahead with the continuous CTG monitoring. The presence of meconium, or if there is a maternal pyrexia, again here is a SBA. When pyrexia is an indication for continuous CTG monitoring, if there is a temperature record of 38 degrees centigrade or above, a single reading, if it is a 38 degree or 37.5 degree on 2 consecutive occasions, which is taken 1 hour apart. Okay, so they'll give 38.5, 39 degree, 2 readings. So single reading more than 38 degree and 37.5 degree or more on 2 occasions which are 1 hour apart. Okay, the various options they will give: 30 minutes apart, 20 minutes apart, 1 hour apart, 2 hour apart. But what does the guideline says? A single reading 38 degree or more, or if it is a 37.5 degree, at least 2 readings should be there at 1 hour apart. Okay, now suspected chorioamnionitis or sepsis, then pain reported by the woman which differs from the routine or normally associated with the contractions. Okay, so what it is, a description of the women is not matching with what is the normal or the natural contraction, that also you put this patient on continuous CTG. Or fresh vaginal bleeding that develops in labor. Okay, any fresh vaginal bleeding, you will put the patient on continuous CTG monitoring. Next is a blood stain liquor with not associated with the vaginal examination, that is likely to be uterine in origin and it may be an indication of antepartum hemorrhage. Now concentrate. Maternal pulse more than 120 beats per minute on two occasions 30 minutes apart. See, there it was a 1 hour apart. Here pulse 30 minutes apart. So 120 beats per minute on two occasions 30 minutes apart. Okay. Now coming to the blood pressure, single reading of systolic blood pressure more than 160 or single reading of diastolic more than 110 is an indication for continuous CTG monitoring. Now, the blood pressure that is more than 140 millimeters of mercury or diastolic of systolic of 140 or diastolic of 90 millimeter on two consecutive occasions which are 30 minutes apart, measured in between the contractions. So when it comes to the monitoring of the pulse and the blood pressure, in that particular the time limit is 30 minutes between the two readings. Is it clear? When we were discussing about the temperature, it was 1 hour between the two readings, that is 37.5 or above. Single reading of 38 degree or 37.5 at 1 hour apart. When it is a pulse, it is more than 120 beats per minute, at least 30 minutes apart. Okay. When it is a blood pressure, single reading of more than systolic of more than 160 or diastolic of more than 110 is an indication. And if it is a more than 140 systolic or more than 90 diastolic, then you should have a two reading at 30 minutes apart. Or if there is a 2 plus protein on urine analysis, then single reading of either is systolic of 140 by 140 millimeters of mercury or diastolic of 90 millimeters of mercury. So if there is a but it associated with the 2 plus proteinuria, that becomes an indication for continuous CTG monitoring. Confirmed delay in the first and second stage of labor, insertion of regional analgesia if the patient is for on epidural analgesia or the patient is on oxytocin, we need to go ahead with the CTG monitoring, continuous CTG monitoring. Is it clear? Any doubt
Yes,
up till
sir.
now?
No. Yes, sir.
Clear. So temperature, pulse, blood pressure, urine albumin status. So these parameters please take into account. Okay. Now consider continuous CTG monitoring if based on clinical assessment and multidisciplinary review, there are concerns about the other intrapartum factors not listed above that will also require continuous CTG. Now coming to the presence of meconium. When assessing the risk at any time during the labor, be aware that the presence of meconium can indicate the possible fetal compromise and may lead to complications such as meconium aspiration syndrome. Consider the character of the meconium as a part of overall clinical assessment in conjunction with the antenatal or intrapartum risk factors and discuss the option of CTG monitoring with the woman. So if you notice that our scenario is given that you have discussed, you have seen the patient and the ARM is done and there is a meconium, the next step will be to discuss with the woman regarding the continuous CTG monitoring because can indicate the possible fetal compromise. Okay. And ultimately it is a shared decision making, so you have to she will make the choice and you have to support her decision. Be aware that meconium is more common in postterm but should still trigger a full risk assessment and discussion with the woman about the option for CTG monitoring. So you need to discuss with the woman regarding the choice of CTG monitoring. Now coming to the use of cardiotopography for monitoring during the labor. Now how this cardiotopography we are going to use in the labor. Now whatever this discussion or the guideline is for monitoring in the labor, the patients not in labor, these guidelines are not applicable. Okay. Review the previous fetal heart rate monitoring result. So during labor, when you are checking or when you are doing a CTG monitoring, if it is already done 1 hour before, that also you will take into account. What is the fetal heart rate, previous fetal heart rate monitoring results, including any previous CTG report as part of hourly risk assessment and in conjunction with the other antenatal or intrapartum risk factors. Okay. So when you do the assessment, you see what was the heart rate finding 1 hour before. If there are changes in the fetal heart rate pattern over time which indicate a change in the baby's condition, review antenatal or intrapartum risk factors for hypoxia. When reviewing the CTG, Assess and document. 1. Contractions. 2nd, baseline fetal heart rate. 3rd, variability. 4th is a deceleration, presence or absence of deceleration, and last is the presence of acceleration. So please see, when you record the CTG, this is the sequence. First, see the contractions, the baseline fetal heart rate, the variability, the presence or absence of the deceleration, and the acceleration. Normally, we first talk about the acceleration, but remember, acceleration are last actually. Okay, so contractions, baseline fetal, you have to see overall like all these parameters, but contractions, baseline fetal heart rate, variability, and presence or absence of decelerations. Okay, and if there are deceleration, what is the characteristic of deceleration if they are present? Okay, if there is a stable baseline fetal heart rate between 110 and 160 beats per minute and normal variability, continue usual care as the risk of the fetal acidosis is low. So if the baseline heart rate is between 110 and 160, okay, in that particular case, you will continue the usual care. Differentiate between the maternal and fetal heartbeats hourly. Okay. And if there are concerns about whether the maternal heart rate is being heard rather than fetal heart rate, discuss with the woman the methods available to differentiate and support her decision on which method she wants to use. Okay, now what are the methods available? 1, what we can do, fetal heart rate auscultation with Pinard stethoscope. 2nd, bedside ultrasound scanning is also available. 3rd, continuous maternal heart rate monitoring. Okay, using a pulse oximeter or the facility on the CTG equipment. So you monitor the maternal heart rate using pulse oximeter. Next, fetal heart rate detection using fetal scalp electrode, which is attached to the baby's head. But be aware, this may detect maternal heart rate if there is no fetal heartbeat. So should always be used in conjunction with the maternal heart rate monitoring. So sometimes fetal heart rate detection, you can use fetal scalp electrode also, but when you use the fetal heart scalp electrode and the fetus does not have a heart that time, or it is an IUD case, then it may detect the maternal heart also. So whenever you are using the fetal scalp electrode, it should be used in conjunction with the maternal heart rate monitoring. Okay, and second, what you do is a simultaneous palpation of the woman's pulse while listening to the fetal heart. So these are the various methods which are available, which you need to discuss with the lady. Be aware that it is particularly important to confirm the fetal heart rate in second stage of labor, when it is easier to mistakenly auscultate the maternal rather than fetal. So the chances of confusion are very high in the second stage of labor. Okay. Now, if concerns about the differentiation between the maternal and fetal heart rate remain, or if the fetal heart cannot be heard, obtain urgent review by obstetrician or senior midwife. So if there are concerns, always take the senior's opinion, obstetrician or senior midwife. Ensure that CTG trace is of high quality, and if not, take action to improve the trace. You have to reposition the tokodynamometer or the transducer, or by using the fetal scalp electrode, etc. Okay, when reviewing the CTG traces, evaluate the changes over a period of time. Document any changes in the CTG trace from previous review. Review the changes alongside any existing and new intrapartum risk factors. So you will take overall factors into consideration. Okay. Now from here onwards, the most important part starts. Okay. Now when you are reporting a CTG, what features you are going to see? Okay. Categorize the 4 features of cardiotocography trace. So CTG has got certain features. So 4 important features are contractions, baseline fetal heart rate, variability, and deceleration. Okay, and they are categorized as white, amber, or red. Okay, indicating increasing levels of concern. Okay, if it is white, usual. Okay, amber, you need to be alert, and red, that is of more concern. Okay, is it clear?
Yes, sir.
So what parameters you are going to see in the CTG trace?
Uh, Contractions,
Contraction, baseline,
baseline,
variability,
fetal heart
deceleration.
rate, variability,
Yes,
and deceleration.
and you will categorize them as a each feature. either as a white, amber, or red. So contractions you will categorize, baseline fetal heart rate you will categorize, variability you will categorize, okay, into these, whether it is white, amber, or red, except contraction. Contraction is only white or amber, okay, but rest of the features are white, amber, or red, okay. So this is actually newer guideline divides. Initially, the classification was different. It was a reassuring or non-reassuring features, etc. But now it is a white, amber, or red. Okay. Now use a tokodynamometer to record contraction frequency and length on the CTG. So how we record the contractions with the help of tokodynamometer. Okay. Use the following work to work out the categorization for contractions. So as already said, you have in contractions white and amber. Okay. If it is a fewer than 5 contractions in 10 minutes, you will note it as a white. Okay. The feature contraction feature as a white. If there are contractions less than 5, remember it is less than 5 in 10 minutes. But if it is a 5 or more, okay, sometimes in the scenario they give you how many contractions, they'll give 5 contractions. So 5 is amber. Okay, 5 or more contractions in 10 minutes leading to reduced resting time between the contractions. Or if it is hypertonus means the contraction is lasting more than 2 minutes, that is called as hypertonus. Okay, then you have to report this contraction feature as a amber. Okay, so this feature may be white or may be amber. Is it clear?
Yes, sir.
Yes, sir.
Okay, so here see this CTG. Now this is the contraction trace. Okay, how many contractions are there in 10 minutes? This is the 10-minute. Okay, this is area corresponds to 10 minutes. Here there are 2 contractions. So what is the feature here? How will you categorize this feature of
White.
contraction? White.
White.
Okay, so
White.
amber will be, when will be amber?
More
5
than 5
or more.
contractions in 10
Yeah,
minutes.
5 or more, and
Or lasting for
if there is
more than 2
More than
minutes.
2 minutes.
yeah, hypertonus, that is more than 2 minutes each contraction. Now see here it is a 1 minute, so this contraction is lasting for 1 minute. Okay, but if this contraction it would have been like this, then it would have been a amber. Is it clear? Okay,
Yes.
now when you see the contractions, practically what when you see the contraction, you immediately look at the heart rate deceleration if it is associated. Okay, so if decelerations are present, evaluate the timing related to the contraction. So you have to classify what kind of decelerations are there, that we will see into the deceleration how. Okay, if 5 or more contractions per 10 minutes are present, now if you have got a 5 or more, then what will be the next step? Perform a full risk assessment. Okay, take action to reduce the contraction frequency as described. So that this also we will see what exactly is to be done. Okay, and explain to the woman what is happening and ensure that she has got adequate pain relief. Okay, so give pain relief also. So you will do the full risk assessment, you will take the steps to reduce the contractions and explain the woman what is happening and give adequate analgesia. Okay, now come next feature is a baseline fetal heart rate. Now we know that the baseline fetal heart rate is between 110 to 160. Now determine the baseline fetal heart rate by looking at the mean fetal heart rate excluding the accelerations and decelerations. Okay, so when you note down the fetal heart rate, baseline fetal heart rate, you have to exclude the accelerations and deceleration, and you have to check for 10 minutes area when there is a fetal heart rate is stable. Okay, when deciding if there is any change in the baseline fetal heart rate, compare it with the earlier CTG or recordings of the previous. Okay, so you have to always compare also. This also we will divide it into white, amber, and red. We have seen contractions were only 2, white or amber. Now baseline fetal heart rate is divided into white, amber, or red. When it is white, when it is 110 to 160 beats per minute, that is normal, then it is white. Amber, increase in the baseline fetal heart rate of 20 beats per minute or more from the start of the labor or since the last review an hour ago. Suppose previously heart rate is 125 beats per minute and now it has become 150. In that particular case, even if it is a 150, but now it has raised by 20 beats per minute, that means it is amber. Is it clear to you?
Yes, sir.
Is it clear?
Yes, sir.
Okay. Or 100 to 109 beats per minute. Okay, then also it is amber. And if you are not able to determine the baseline, then also it is amber. Okay. Now, what is red feature? If the heart rate is below 100, then it is red. Or if it is above 160, then it is red. Okay. So 110 to 160 is white. Below 110 is red. Below 100 is red. And above 160 is red. Okay. Below 100 is red. Above 160 is red. Now, between 100 and 109 is amber. Or increase in the baseline heart rate above 20 beats per minute from the previous finding. Or if you are not able to determine the baseline fetal heart rate, in that particular case, it is amber. Okay. So this is clear, is it? Okay. Shall we go
Yes,
ahead?
sir.
Yeah. So here, when you find out the baseline fetal heart rate, you have to remove the accelerations and decelerations. You will not take into account these accelerations. Okay, you have to exclude this area and come to the stable heart rate pattern. So you will take into account this. Okay, and you will see the where it is stable. Okay, this particular line you will see around 120 beats per minute. Is it clear? Okay, so this is the 120 beats per minute. You have to exclude the acceleration part or the deceleration part if it is present, and then you decide the stable heart rate. Okay, then variability. Now, how the variability is calculated? Determine the variability by looking at the minor oscillations in the fetal heart rate, which usually occur 3 to 5 cycles a minute. Measure it by estimating the difference in the beats per minute between the highest rate and the lowest rate in a 1 minute segment of the trace between the contractions, excluding the decelerations and the accelerations. Okay, so if there is an absence of variability, carry out review of the whole clinical picture with low threshold of expedited birth, as this is very concerning feature. Use the following to work out the categorization for the fetal heart rate variability to work out the overall categorization of the CTG. So when you measure the variability, how will you measure the variability? You will look at the minor accelerations in the fetal heart rate, which usually occur 3 to 5 cycles in a minute, and you will measure by estimating the difference in the beats per minute between the highest rate and the lowest rate in 1 minute segment. Okay, okay, and that is also categorized as a white, amber, or red. Okay, white when the variability is between 5 to 15 beats per minute. Amber when the variability is less than 5 beats a minute for between 30 to 50 minutes. Remember, if the variability is less than 5 beats per minute, more than 30 minutes, but less than 30 minutes, it is amber feature. Okay, if it is more than 25 beats per minute, but more than 10 minutes, then again it is an amber feature. Okay, so normal variability between 5 to 20. If it is less than 5 beats per minute, but lasting more than 30 and less than 50 minutes, then it is an amber feature. Okay, but if this is less than 5 beats per minute, but lasting more than 50, then it becomes the red feature. Okay, is it clear? Is it clear?
Yes, sir.
Yes, sir.
Okay, next, amber is more than 25 beats per minute, but up to 10 minutes. So normally is between 5 to 25, but if it is more than 25, but up to 10 minutes, then it is amber. But if it is more than 25 beats per minute and more than 10 minutes, it is red. Okay, and if it is a sinusoidal, then also it is red. So remember, normal is 5 to 25, less than 5 beats per minute. If it is more than 50 minutes, then it becomes red. If it is between 30 and 50 minutes, then it is a amber. Okay, clear? Okay, but sometimes they give you confusing. that it is less than 5 beats per minute for 20 minutes only. Okay, then it does not fit into umber. Okay, by definition, it should be between 30 and 50. Okay, and 50 is included into the umber. Sometimes they give you the borderline. It is 30 minutes. Okay, then umber. If it is 50 minutes, umber. But if it is more than 50 minutes, then it is red. Suppose a figure of 50 is given, 50 minutes. In that particular case, it is umber. Is it clear? Okay. So take the following into account when assessing the fetal heart rate variability. Variability normally between 5 and 25 beats per minute. Intermittent periods of reduced variability are normal, and especially during periods of quiescence. Certain medicines such as opioids may lead to reduction in variability. So opioid can have an effect, and that will reduce the variability. But all other intrapartum risk factors should be carefully reviewed. Okay. Increased variability refers to oscillations around the baseline fetal heart rate or more than 25 beats per minute, and shorter episodes lasting few minutes may represent worsening fetal condition. Okay. What you will do? Obtain urgent review by the obstetrician or senior midwife, and consider expediting the birth if there is an isolated reduction in the variability less than 5 beats per minute but more than 30 minutes when there are antenatal or intrapartum risk factor. Okay, so you have a less than, so this is a umber feature, less than 5 beats per minute for more than 30 minutes. It is an, but there are antenatal or intrapartum risk factors. In that particular case, what you do? You will consider the expediting the birth after review by the senior obstetrician or midwife. Okay, or there is a reduction in the variability less than 5 beats per minute combined with other CTG changes, particular rise in the fetal heart rate. So if there are no antenatal or intrapartum high risk factors, but there are other CTG parameters which are concerning, like fetal heart rate, uh, these features are also concerning, then also you will consider the expediting birth. Okay. Now let's see variability. So this variability, again, when you count the variability, you will go for this particular 1 minute area, and you will see the highest oscillations around the basal heart rate. Okay, so you will see the highest and the lowest. Okay, so this particular, okay, this is around 10 bits, sorry, 20 bits. Okay, so here, from here up and here down. Okay, so here up and down, so around 15 to 20, this is 20 bits per minute. Okay, here also it is 20 bits per minute. Okay, so here it is 10 bits per minute. Okay, so this is how the variability is calculated. Okay, normal is 5 to 25 beats per minute. Okay, now this is the reduced variability. Okay, less than 5 beats per minute, this is the reduced variability. Now coming to the decelerations. So this is the third feature. This is the fourth feature. First, what we saw is the contraction. Second, we saw baseline fetal heart rate. Third, we saw variability, and fourth is the deceleration, and the last one will come the acceleration. Okay, but these four features are important. Okay, now define decelerations as a transient episodes when the fetal heart rate slows to below the baseline level by more than 15 beats per minute, with each episode lasting 15 seconds or more. This is what we know well. When you will say there is a deceleration, there is a decrease in the fetal heart rate by less than 15 beats per minute below the baseline and lasting for 15 seconds or more. That is what we call as a deceleration. And this deceleration may be shallow if there is a reduced variability, associated reduced variability. In that particular case, it will look a little shallow. Okay, when assessing the significance of deceleration in the fetal heart rate, consider the timing, that is whether it is early, variable, or late in relation to the peaks or the duration of contraction. So you have to classify what type of deceleration it is, whether it is early, variable, or late, the duration of the individual decelerations, whether or not fetal heart rate returns to the baseline heart rate, how long they have been present, and whether they occur with more than 50% of the contractions. That is called as repetitive. Okay, this is very important. Repetitive decelerations. When the decelerations are happening are associated with more than 50% of contractions. So suppose in 10 minutes there are 5 contractions and 3 contractions have the deceleration. They are called as repetitive decelerations. Okay, if there is only one deceleration among those 5 contractions, then this is non-repetitive deceleration. Is it clear? What do you mean by repetitive deceleration? Is it
Yes, sir.
clear? Okay,
Yes.
the presence or absence of shouldering and the variability within the deceleration. So this you have to take into account. Regard the following as a concerning characteristic of variable. Now you have deceleration which is a variable deceleration, but this variable deceleration may have a concerning characteristic. Now what is this concerning characteristic? If it is lasting more than 60 seconds, if there is a reduced variability within the deceleration, so there is a deceleration, but within the deceleration there is a reduced variability, that is a concerning feature. Failure or slow to return to the baseline fetal heart rate. So if it does not come back to the normal again, or if there is a slow returning to the baseline, loss of previously present shouldering. So these are the concerning features of variable deceleration. Okay, there are 4 features. These 4 features you can note it down. One is a lasting more than 60 seconds, reduce variability within the deceleration, failure or slow to return the baseline heart rate, and loss of previously present shouldering. These are the concerning features of variable deceleration. Describe variable decelerations as early, variable, or late. Do not term these decelerations as typical or atypical. We will see what is early, what is variable, and what is late at the end. Okay, use the following to work out. Again you will classify whether it is a white, amber, or red. Now what is white? If there are no deceleration, it is white. If there are early deceleration, again it is white. Remember, early decelerations are white. That is a normal feature. Variable decelerations you will label as a white if it does not have a concerning features. Okay, we have seen the concerning features, 4 concerning features just now we have seen. Okay, lasting more than 60 seconds, reduced variability within the deceleration, failure or slow to come back to the baseline fetal heart rate, and loss of previously present shouldering. These are the concern. If they are not there, then it is white. Okay, then amber. What is amber? Repetitive variable deceleration with any of the concerning characteristics. Now you have a variable deceleration which is repetitive. That means more than 50% contractions have a variable deceleration with any of the concerning characters, but it is lasting less than 30 minutes. Okay, then it is amber feature. You have variable deceleration with any concerning characteristics for more than 30 minutes. Again, it is a amber feature. And repetitive late deceleration for less than 30 minutes. We have seen the deceleration can be early deceleration, it can be late deceleration, or it can be variable deceleration. Okay, now which are the decelerations which are white? If there is no deceleration, then
Early
if the
deceleration, variable deceleration with
variable deceleration
no
without
concern.
any concerning characteristic. Okay, without any concerning, or early deceleration is also white. Now coming to the amber. In amber, when there is a variable deceleration with any of the concerning characteristic, and if it is repetitive, then it is less than 30 minutes. Suppose if it is not repetitive but lasting more than 30 minutes with concerning characters, then also it is amber. And repetitive deceleration for less than 30 minutes. Okay, if it is a late dissolution, repetitive but less than 30 minutes, it is amber. Now coming to the red. Repetitive variable dissolution with any concerning characteristics for more than 30 minutes, repetitive late dissolutions for more than 30 minutes, and acute bradycardia or single prolonged dissolution lasting 3 minutes or more is a red feature. So remember, it is only what you have to see, the duration. It is a variable dissolution with any concerning characteristic. If it is repetitive, less than 30 minutes is amber. If it is repetitive but more than 30 minutes, it is red. If it is non-repetitive, okay, in that particular case, more than 30 minutes is amber, okay, and late deceleration is more than 30 minutes is always red, okay. Repetitive late deceleration less than 30 minutes is amber, and more than 30 minutes is red. And other red feature is acute bradycardia or single prolonged deceleration lasting 3 minutes or more. Any confusion over here? Little difficult to understand because of the words like repetitive, but just you can take photograph and concentrate on the slide again and again, okay. So let us see about the deceleration. What type of deceleration you see here? Yes, can anyone tell me?
Early deceleration.
Yes, this is,
Only
see,
deceleration, sir.
this is early deceleration. So
Early
okay,
deceleration.
so this is the contraction. At the peak of the contraction, this is the deceleration, okay. So this is the early deceleration. Now this is a variable deceleration. It does not have any specific relation with the contractions, okay. This is variable deceleration. Now this is the late deceleration. The onset is after the contraction, okay. Okay, that is the variable deceleration, sorry, late deceleration, okay. And this is a prolonged deceleration. Here you see this is a prolonged deceleration, okay. That is also red feature. No, we have just seen the red features, okay. What were the red features? Repetitive deceleration with any concerning characteristics for more than 30 minutes, repetitive late deceleration for more than 30 minutes, and acute bradycardia or a single prolonged deceleration lasting 3 minutes or more. So this deceleration, this is lasting more than 3 minutes. So this is lasting more than 3 minutes. See, 1, 2, 3, 4, 5. Okay. So this is also a red feature, okay. This sinusoidal pattern is also a red feature. That indicates what? Sinusoidal pattern indicates fetal
Severe fetal anemia.
anemia, okay. So start conservative measures and carry out urgent obstetric review if there are decelerations lasting longer than 30 minutes in presence of either a rise in baseline heart rate or reduced variability. Take into account antenatal intrapartum risk factors such as suspected sepsis or meconium or slow progress of labor, etc. Okay. If variable deceleration persists and other CTG changes are present, obtain urgent review by the obstetrician and senior midwife, as there is a risk of fetal compromise and acidosis. If variable deceletions with no concerning characteristics and no other CTG changes, including no rise in baseline fetal heart rate, are present, observe. Be aware that these are very common and can be a normal feature, okay. So this last variable decelerations without any concerning characteristic, without any CTG other changes, everything is normal. So this is very common and can be a normal feature in otherwise uncomplicated labor and birth, and are usually a result of cord compression. Support the woman to change the position or mobilize. So you get such kind of picture. You just, what you need to do, some conservative measures such as change the position or mobilize the woman, okay. Take the following into account when categorizing the early decelerations, okay. They are uncommon, benign, and usually associated with head compression. So the early deceleration is because of head compression. Sometimes they can ask you this, okay. Early deceleration is because of head compression. Variable decelerations are because of the cord compression, okay. They are not accompanied by any CTG changes such as reduced variability or rise in the basal fetal heart rate, etc. Okay. Now last feature is acceleration. Define the acceleration as a transient increase in the fetal heart rate 15 beats per minute or more, lasting 15 seconds or more. Take the following into account when assessing the accelerations in fetal heart rate. The presence of fetal heart rate accelerations, even with reduced variability, is generally a sign that the baby is healthy. Sometimes you can have a variability which is reduced, but still there are acceleration, then it is a good sign, okay. Is it clear what does this particular significance of acceleration is there? Okay,
Yes,
the
sir.
absence of acceleration on otherwise a normal CTG trace does not indicate fetal acidosis. So suppose the rest of the features are normal, There are no deceleration, fetal heart rate is normal, but there are no acceleration. It does not mean that there is a fetal acidosis. Okay, so absence of acceleration does not indicate that there is a fetal acidosis, but the presence of acceleration, even with reduced variability, is a sign that the baby is healthy. Okay, so this you have understood. Okay, so categorization of the CTG. Now from here onwards, now what we are going to categorize, the whole CTG. Up till now we have categorized individual feature as amber, white or red. Now when we want to give the interpretation of the whole CTG, how we are going to categorize. Okay, include the CTG categorization as a part of full assessment. Categorize CTG traces as follows based on whether each of four features, that is contraction, baseline, variability and decelerations, have been scored as a white, amber or red. Now first thing, you will see these four features, you will categorize this as a white, amber or red, and then you will give the overall CTG review. Okay, and that is labeled as a normal, suspicious or pathological. Okay, the overall CTG may be normal if there are no amber or no red features. All four features are white. Okay, so contractions, baseline fetal heart rate, variability and decelerations, all four features, if they are white, then we call it as a normal CTG. Okay, second categorization is a suspicious CTG. If there is any one amber feature, okay, either contraction or fetal heart rate or variability or deceleration, if any of them have got amber feature, on any one amber feature is, then we will categorize this CTG as a suspicious CTG. Okay, then third is a pathological. So any one feature is a red or two or more amber features, okay, will be categorized as a pathological CTG. So CTG is of three types. Okay, individual feature is of three types and CTG is of three types, but they are different. Individual feature may be white, red or amber, while overall CTG may be normal, may be suspicious or may be pathological. Normal, when all four features are normal, there is no red, there is no amber, then it is normal. Then it is a suspicious. When it is suspicious, if there is one feature is amber, then we call it as a suspicious. And pathological, any one red or two or more amber features, then we call it as a pathological. Okay, take into account any change in the categorization of the CTG alongside. So it may happen that initially the CTG was normal, it may become over a period of time pathological, or it may become suspicious, or suspicious may become pathological. Okay, or with conservative measures this suspicious may come back to normal. So that is why you need to see the previous findings also. Take into account any change in the categorization of the CTG alongside other antenatal and intrapartum risk factors for hypoxia. Discuss the change and its implications with woman and take into account her preferences when deciding how to proceed. Okay, so these are the accelerations. Okay, so this is actually a normal CTG. Okay. Now, special considerations for CTG traces in the second stage of labor. What we have seen up till now is a first stage of labor. Take into account that the interpretation of the CTG traces in the second stage of the labor is more challenging than in the first stage. Have a lower threshold for seeking a second opinion for assistance in the second stage of labor. Ensure that the fetal heart rate is differentiated. We have seen that most of the time the mistakes in the fetal and maternal heart rate happen in the second stage. Okay, so you have to be very careful. Consider monitoring the baby with fetal scalp electrode if there is a concern about confusing the fetal heart rate. But if this cannot be achieved, expedite the birth. So what you do, one, you can use the fetal scalp electrode. If that is not possible, then just you go ahead with the expediting the birth. In the second stage of the labor, if the fetal heart rate accelerations are recorded, be aware that these are most likely to be maternal pulse. Check whether the maternal or fetal heart rate is being detected. Okay, if the fetal heart rate decelerations are recorded, look for other signs of hypoxia like baseline fetal heart rate or reduction in the variability, etc. Now take into account the onset of hypoxia is both more common and more rapid in the active second stage of labor. Take an increase in the baseline fetal heart rate of 20 beats a minute or more from the start of the labor since the last review and ago as a red feature in active second stage of the labor. So if this feature is there, then it is a red in the second stage. Okay, this is considered as a red feature in active second stage of labor if there is an increase in the baseline fetal heart rate 20 beats per minute. So in the first stage we have seen this as a amber feature, but in the second stage this is the red feature. Is it clear?
Yes, sir.
If the
Yes, sir.
if the CTG concerns arise in the active second stage of labor, now you have concerns about the CTG in the active second stage of labor. What you are going to do? You will do obstetric review, consider discouraging pushing and stopping an oxytocin infusion to allow baby recover unless the birth is imminent, and agree and document a clear plan with the limits for the next review. Okay, so the next step is a urgent obstetric review, discourage the pushing, stop the oxytocin, okay, and agree and document clear plan with time limits for the next review. So okay, now making care decisions based on the cardiotocographic trace. Now if your CTG categorized is as a normal CTG, then what you will do? You will do continuous CTG unless it was started because of the concerns arising from intermittent auscultation. We have seen if there is a concern in the intermittent auscultation, you put the patient on CTG. CTG is normal for 20 minutes, then you will go back to the intermittent auscultation. But if there are some return high risk, you will continue the monitoring with the CTG. Suppose there are antenatal or intrapartum high risk, then you will continue the CTG and usual care. Continue to perform the full risk assessment at least hourly and document. So hourly assessment will go on. Okay, if it is a normal. Suppose your CTG is categorized as suspicious and there are no other concerning factors. Okay, there are no maternal or fetal high risk factors and the CTG is categorized as a suspicious. In that particular case, you will perform a full risk assessment, including full set of maternal observations, taking into account the whole clinical picture and document the findings. Note that if the accelerations are present, then the fetal acidosis is unlikely. Okay. And if CTG trace was previously normal, consider possible underlying reasons for the change. So you will see, is there any other underlying cause because of which the CTG has become suspicious? Okay. Now, third scenario in which you have a CTG trace again suspicious, but there are additional intrapartum risk factors such as the progress is slow or there is a sepsis or meconium. Again, you will do the full risk assessment. You will find out is there any underlying cause. You will undertake conservative measures. Okay, here you will undertake the conservative measures and urgent review by the obstetricians and senior midwife and consider fetal skull stimulation or expedite the birth. So if you have a suspicious CTG, but there are additional intrapartum risk factors, you will definitely do the full risk assessment. You will undertake the conservative measures. You will do the urgent review by the obstetrician or senior midwife. Then you will do the fetal skull stimulation and or expedite the birth. Okay, is it clear? Now
Yes,
you
sir.
have the CTG, which is categorized as a pathological. Again, urgent review by the obstetricians and the senior midwife. Exclude acute events. So this CTG has become pathological. That means you have to rule out these acute events like a cord collapse, abruption, rupture, etc. that need immediate intervention. Perform a full risk assessment, including full set of maternal observations, taking into account the whole clinical picture and document the findings. Consider the possible underlying causes and undertake conservative measures as indicated. Now, if the CTG trace is still pathological after implementing the conservative measures, then you will obtain further urgent review by obstetricians and senior midwife, evaluate the whole clinical picture and consider expediting the birth. If there are evolving intrapartum risk factors for fetal compromise, have a very low threshold for expediting the birth. Okay, so here you have to expedite the birth. Now, if there is acute bradycardia or single prolonged deceleration for 3 minutes or more, urgent obstetric review. If there has been a acute event such as cord prolapse, abruption, or uterine rupture, again go for expediting the birth. Consider possible underlying cause and take conservative measures as indicated. Okay, so this is how we need to manage. make preparations for urgent birth, including requests for pediatric and neonatal support, expedite the birth if the acute bradycardia persists for 9 minutes or less if there are significant antenatal or intrapartum risk factors for fetal compromise. So if there is acute bradycardia and it persists for 9 minutes or less if there are significant antepartum or intrapartum risk factors for fetal compromise. If the fetal heart rate recovers at any time up to 9 minutes, reassess any decision to expedite the birth, but take into account other antenatal and intrapartum risk factors and discuss this with the woman. Okay, so if there is a acute bradycardia and the duration is for 9 minutes or less than 9 minutes and there are additional factors, in that particular case you think of expediting the birth. Okay, now underlying causes and conservative, we have seen take out conservative measures, do the conservative. Now what the conservative measures means it is a maternal position, as this can affect the uterine blood flow and cord compression, encourage the woman to mobilize or adopt alternative position or to avoid being supine. Okay, second, hypotension, do not offer IV fluids to treat fetal heart rate abnormalities unless the woman is hypotensive or has signs of sepsis. Okay, so suppose your CTG is not CTG is pathological or suspicious, then don't offer IV fluids, okay, to treat the fetal heart rate. IV fluids are indicated only if the mother is hypotensive or she has got the signs of sepsis. Then the IV fluids are indicated. If the woman is hypotensive secondary to an epidural top-up, start IV fluids or move her to the left lateral position and call anesthetist review. Okay, so this will be the next step. If there is a epidural top-up is given and then there is a hypotension which is noted, then you give IV fluids, left lateral position and anesthesia review. Now, excessive contraction frequency. Reduce the contraction frequency by reducing or stopping the oxytocin if it is being used. Offer a tocolytic drug or suggested regime is subcutaneous terbutaline 0.25 milligram. So a few minutes back, I told you we will see how to deal with this increased contraction frequency. So what you will, if the patient is on oxytocin, you stop the oxytocin or offer the tocolytic drug. It is a subcutaneous terbutaline 0.25 milligram. Remember the dose, remember the route and drug. Okay, do not offer maternal facial oxygen therapy as a part of conservative measures because it may harm the baby. However, it can be used if it is given for maternal issues such as hypoxia or as a part of pre-oxygenation before potential anesthetic. Okay, so oxygen, IV fluids, these are not indicated unless there is a hypoxia or hypotension. Okay, they will not treat the fetal heart rate patterns provided. Okay, do not offer amnio infusion for intrauterine fetal resuscitation. Now, certain definitions we have seen: early deceleration, late deceleration, these are words. Now, how the early deceleration is defined? Early deceleration, repetitive and periodic slowing of the fetal heart rate with onset early in the contraction and return to the baseline at the end of the contraction. These are uncommon. Okay, so early deceleration we know well. Then hypertonus, a contraction lasting 2 minutes or longer is a hypertonus. Late deceleration, repetitive and periodic slowing of the fetal heart rate with onset mid to the end of contraction. Okay, onset is mid to the end of the contraction and the lowest point is more than 20 seconds after the peak of the contraction and ending after the contraction. Okay, so the lowest point of the deceleration will be 20 seconds after the peak of the contraction. Okay, and it ends after the contraction. Now, what is variable deceleration? Intermittent and periodic slowing of the fetal heart rate with a variable time in relation to the contractions. Okay, now coming to the fetal scalp stimulation. If the CTG trace is suspicious with antenatal or intrapartum risk factors for fetal compromise, then consider digital fetal scalp stimulation. Remember, this fetal scalp stimulation has got a role when the CTG trace is suspicious with antenatal or intrapartum risk factors for compromise. Then you have to go ahead with the digital fetal scalp stimulation. If this leads to accelerations in the fetal heart rate and sustain improvement in the CTG trace, continue to monitor the fetal heart rate and clinical picture. So sometimes they'll give that there are some antepartum or intrapartum risk factors. These are the finding, and interpretation will be CTG is a suspicious, that you have to interpret, and then they will ask you the next step. So next step will be digital scalp stimulation here. Okay, and if the digital scalp stimulation, there is a sustained improvement in the CTG trace, there are acceleration, then you will continue to monitor the fetal heart rate and the clinical picture. Be aware that absence of acceleration in response to fetal scalp stimulation is worrying sign that fetal compromise may be present and that expedited birth may be necessary. So if there are no acceleration in response to fetal scalp stimulation, you have to go for expediting the delivery. Okay. Now, about the fetal blood sampling. What does the NICE say about the fetal blood sampling? Fetal blood sampling, NICE is unable to make recommendation about the fetal blood sampling because of the limited evidence. Now, one or two important SBAs are here. Always you will find the SBAs on from this slide. Record keeping for the cardiotocography. Date and time clocks on the cardiotocograph monitor are set correctly. Ensure the recording or paper speed is set at 1 centimeter a minute and that adequate paper is available. So this is SBA. What is the speed of the paper as per the NICE guideline? It is 1 centimeter per minute. Okay. CTG paper speed is 1 centimeter per minute. This is SBA frequently asked. Then label traces with the woman's name, date of birth, hospital number, NHS number, etc. That you have to note it down. Okay. Then how many years you will keep the record? Individual units should develop a system for recording relevant intrapartum events. For example, vaginal examination, sighting of an epidural in standard notes and on the cardiotocograph trace. Keep the cardiotocograph trace for 25 years and if possible store them electronically. So how many years you have to store? For 25 years. This is also SBA. Okay. And one more SBA in the next line. In cases where there is a concern that the baby may have sustained a possible brain injury, photocopy cardiotocograph traces, or if they are not available electronically, to store them indefinitely in case of possible adverse outcome. So now in that particular case, there is no time limit. You have to keep them indefinitely. So if there is any concern about the baby, then you will keep this record indefinitely. If there are no concern about the baby, it is for to be kept 25 years. Okay. So these two are SBA. Okay. So this is also a normal CTG. So that finishes the topic of fetal monitoring, the NICE guideline.